Good evening, everyone, to this evening session of the Argentinian HIV Clinical Forum 2020. I'm Mauro Schechter, and I have the honor to chair this session. And I'll have to speak in English because that's what I've been asked to do. Otherwise, I'll speak in poor Spanish in Portuñol, in fact. But as you know, this program has been developed by a group of individuals that were chaired by Jonathan Shapiro, Pedro Khan, and myself. This session, you already had the first two sessions in the morning, in the afternoon, and now having the third session in the evening. I ask you to please submit your questions during the session, and we'll do our best to respond to all of them during the roundtable after all the three presentations. These are the faculty. You had the opportunity to meet all of them during the first two sessions, except for the three speakers that I'll introduce now for our session. This meeting was made possible thanks to a generous grant from Viv Healthcare. It's really important to stress that Viv Healthcare is not involved in any way in the development of the content or selection of faculty for this activity. All the selection of faculty, the content is the entire responsibility of virology education and of the organizers. These are the faculty for the session 3, which is entitled HIV Therapy in the Near Future. And the speakers are, as you know, Dr. Landovitz, Huésped, and Branson. The first talk will be given by Dr. Landovitz. It's called Long-Acting Integrase Inhibitors for PrEP. Dr. Landovitz is a well-known investigator. He's a professor at UCLA. He worked in Vietnam earlier on, and he's extremely well known to every one of us for his landmark work with the study HPTN 083, which is really landmark, as I said, was a game changer. It will change the landscape for HIV in the near future. So Rafi, the floor is yours.
Thank you. I would like to express sincere gratitude to the Argentinian Clinical Forum organizers for the opportunity to present these study results on behalf of my co-chair, Dr. Beatrice Grinstein, and the rest of the HPTN 083 study team. The final results of HPTN 083 pre-exposure prophylaxis containing long-acting injectable cabotegravir is safe and highly effective for cisgender men and transgender women who have sex with men. These are my co-authors, and these are my disclosures. Today, I will briefly provide some background and context for the origin of the HPTN 083 study. I will review the HPTN 083 study design and objectives and summarize the statistical methods of the study. I will then present the HPTN 083 study population, findings related to HIV incidence overall, and in each study arm, safety of both study products, the details of HIV acquisition events, and some additional outcomes of interest, including sexually transmitted infection rates and weight changes. A number of critical analyses are still in progress, and I will review and contextualize these. I will then conclude with some summative comments and observations. It is now well known that tenofovir preparations in combination with emtricitabine are highly effective products for HIV prevention across population and contexts, with a series of rigorously conducted randomized clinical trials demonstrating high levels of protection against HIV infection when used with fidelity and a margin of forgiveness to non-adherence for rectal protection, but much more rigorous adherence required to maintain vaginal protection. Despite these impressive clinical trial successes, the public health benefits of PrEP scale-up have not been universally realized, with young adults, Black or African American and Latinx, gay men and transgender individuals continuing to be disproportionately affected by HIV and low uptake, adherence, and persistence to current PrEP regimens. Recent advances in PrEP have included the development of a monthly dapivirine ring with efficacy against vaginal HIV acquisition, which was recently approved in Europe, and the approval of daily oral TAF-based PrEP by the US FDA this past October. HPTN 083 aimed to build on accumulating evidence for antiviral activity of long-acting injectable cabotegravir, a novel integrase strand transfer inhibitor seen when used in combination with long-acting injectable rilpivirine for maintenance of virologic suppression in persons living with HIV. a combination that is currently under regulatory review in the United States, but approved in Canada. We compared a PrEP regimen containing long-acting injectable cabotegravir to daily oral TDF-FTC for HIV prevention in a phase 2b/3 randomized, double-blind, double-dummy clinical trial conducted at 43 sites in North and South America, Asia, and Africa, including at 2 sites in Buenos Aires, Argentina. The study enrolled cisgender men and transgender women who have sex with men, ages 18 and above, at elevated risk for HIV infection as defined on this slide, who were generally in good health, had no evidence of viral hepatitis infection, and no history of seizures or seizure disorder, and had no contraindications to gluteal intramuscular injections. The planned enrollment was 5,000 participants, and pre-specified key population metrics included that at least 50% of participants would be under the age of 30, at least 10% of participants would be transgender women, and that minimum 50% of the US enrollment would be Black or African American. Further details of study outcomes in these key populations were presented by my co-chair, Dr. Beatrice Grinstein, at the AIDS 2020 conference, which you can find online as abstract OACLB 0101. The study's primary efficacy and safety endpoints are listed on this slide. HPTN 083 was a study at 3 distinct phases or steps. After 1-to-1 randomization to either cabotegravir or TDF-FTC, participants began step 1, where either active cabotegravir 30 milligram tablets and a TDF-FTC placebo were administered, or active TDF-FTC with a tablet cabotegravir placebo. This was to be taken for approximately 1 month to establish the safety and tolerability of the short-acting cabotegravir formulation prior to administration of the long-acting formulation. Participants with at least 50% adherence to daily oral tablets by pill count and acceptable safety profiles advanced to step 2, the blinded comparison of oral and injectable study products. Cabotegravir arm participants, shown on this slide in orange, received a 3 milliliter gluteal intramuscular injection of cabotegravir totaling 600 milligrams, beginning at week 5, again at week 9, and every 8 weeks thereafter, and continued their daily oral TDF-FTC placebo tablets. The TDF-FTC arm participants, again shown in blue on this slide, continued to receive active blinded daily oral TDF-FTC and received placebo injections consisting of 20% intralipid feeding solution, which was visually indistinguishable from the active cabotegravir product on the same schedule as the active injections. The oral injectable comparison continued for 3 years after enrollment. All participants who discontinued injections prematurely were provided open-label TDF-FTC for up to 1 year after their final injection to provide ongoing HIV protection during the tail of long-acting cabotegravir. Participants were then linked to local HIV prevention services. All participants had frequent lab safety assessments, every 6-month asymptomatic sexually transmitted infection testing more frequently if they were symptomatic, adherence support, and risk reduction counseling, including condom and lubricant provision at all study visits. Going forward, I will continue to use this color convention of the cabotegravir arm results being shown in orange and the TDF-FTC arm results being shown in blue. HPTN 083 was designed as a non-inferiority study using a relative non-inferiority margin of 1.23, an alternative hypothesis for the CAB versus TDF-FTC hazard ratio of 0.75, and aimed to enroll a population with a background HIV incidence of approximately 4.5 per 100 person years. The sample size was predicated on a population whose adherence by detectable plasma tenofovir concentrations would be approximately 57%. The study was planned for 172 incident HIV events to be fully powered, with pre-specified interim analyses when 25, 50, and 75% of endpoints had been observed, with extremely rigorous criteria for early stopping. The study was reviewed at regular intervals since its inception in December 2016 by an independent data safety monitoring board at the NIH. The first interim analysis, with 25% of endpoints having been accrued, occurred on May 14th of 2020. At that DSMB review, the board recommended stopping the blinded portion of the study for having met the rigorous criteria for definitive demonstration of high levels of efficacy for cabotegravir compared to TDF-FTC. They recommended public dissemination of the results and that participants be unblinded and offered cabotegravir as soon as the study supply was able to do so. At the time of the blinded study stopping, 4,570 participants had been enrolled and randomized. The intent to treat cohort excluded 4 participants who did not meet inclusion/exclusion criteria of the protocol, and therefore included 4,566 participants. The primary efficacy cohort was pre-specified to exclude participants, 5 in this case, who were found to have been HIV infected prior to exposure to any study products, and an additional 71 participants who had no follow-up visits at which HIV status could be determined. Retention overall was approximately 90% at 6 months and had decreased to 75% by 24 months. The intent to treat study population is described here. Key populations were generally well-balanced across randomized treatment arms. You can see that 567, or 12.4% of the overall population, was represented by transgender women, and fully 2/3 of participants were under the age of 30, with a median age overall of 26. Regional enrollment distribution is represented also on this slide. Approximately 50% of the US enrollment, self-identified as Black or African American, has been pre-specified in the study protocol. These are the primary study results. Overall, we observed 52 incident HIV infections and a total of 6,389 person years of follow-up. Individual participant median follow-up was 1.4 years. This resulted in a pooled HIV incidence of 0.81% with a 95% confidence interval of 0.61 to 1.07. In the lower left panel, you can see that in the CAB arm, we observed 13 incident HIV infections among 3,202 person years of follow-up for an incidence rate of 0.41%. In the TDF-FTC arm, we observed 39 incident HIV infections in a total of 3,187 person years of follow-up for an incidence rate of 1.22%. These incidence rates yielded a hazard ratio of 0.34 in the lower right panel, with a 95% confidence interval of 0.18 to 0.62. This result excluded not only the pre-specified non-inferiority margin of 1.23, the unity result of 1.0, but also the alternative hypothesis of 0.75, definitively and unequivocally establishing superiority. Showing here is the cumulative incidence plot of the intent to treat population. The plot demonstrates the timing of infections in each arm and the highly statistically significant result of a hazard ratio of 0.34 with a significant p-value. The next series of images describes the current state of our understanding of the 13 incident HIV infections identified in participants receiving cabotegravir, and also the 2 participants exposed to cabotegravir who were subsequently on back testing found to have been HIV infected prior to any study product administration. I will preface this discussion by noting that we do not at this time have the results of drug concentration testing or resistance testing for any of the incident or prevalent HIV infections found in this study. That work is proceeding as rapidly as possible during the current SARS-CoV-2 pandemic. To orient you, I have grouped the 15 cases into 4 categories that I will briefly describe. The percentage number to the right of each case identifier indicates the pill count-based adherence recorded by the site during the step 1 oral lead-in. The numbers above each segment represent the interval weeks between events. The syringes represent the timing of research site administered injectable study product. The hatched orange lines represent a delay in injectable study product administration. A hatched blue line indicates the approximate date that the participant would have been anticipated to run out of TDF-FTC had it been taken daily as prescribed. The gray segments indicate periods of time at which no study-provided study products were dispensed in the setting of participants defaulting from study visits. Daggers represent HIV acquisition events whose dates are still not final due to ongoing sample back testing. Cases A1 and A2 represent the 2 participants found to have been infected with HIV prior to administration of any study products on sensitive back testing of stored specimens. The infections were not detected at the site until the time of study product discontinuation in these plots. In the case of A2, this delay in diagnosis resulted in administration of 1 active CAB long-acting injection in the context of HIV infection. Cases B1 to B5 represent participants who were found to have HIV infection after a prolonged hiatus from their last cabotegravir administration. 2 of these participants, B1 and B4, had been provided open-label TDF-FTC after premature discontinuation of CAB injections. B1 was lost to follow-up and then represented over 1 year after the last TDF-FTC resupply and was found to have acquired HIV at that time. B4 was in the middle of a 1-year course of post-injection TDF-FTC when found to have acquired HIV. C1 to C3 represent HIV infections that occurred during the oral lead-in period. 2 of these were delayed in detection at the site and therefore were also exposed to injectable cabotegravir after infection. Pill counts of all 3 participants do not explain the HIV acquisition. Detailed HIV detection assays and molecular clocking studies are being pursued to establish as precisely as possible the timing of these infections to help clarify the timing of onset of protection of oral cabotegravir. Cases D1 to D5 are of particular interest as far as we're able to establish acquired HIV despite excellent adherence to oral cabotegravir and with the unique exception of one 10.7-week interval between participant D1's 5th and 6th injections received cabotegravir as scheduled. Detailed pharmacokinetic analyses of these participants will be critical to the understanding of what circumstances were permissive to HIV acquisition in these cases, as they will be with all of these incident cases. Some might note that the absent cabotegravir drug concentrations and resistant profiles, these cases are extremely challenging to interpret, and we look forward to sharing results in a peer-reviewed setting as soon as possible after the results are available. As is known to be the case with TDF-FTC PrEP, delays in the reactivity of HIV diagnostics, including nucleic acid testing, can complicate identification of HIV infection in the context of ARV-based PrEP use. It appears that cabotegravir is no exception to that observation. On this slide, you can see depicted by the asterisks the timing of the first detection of HIV infection by the site delayed substantially in 7 of these 15 participants. These are the 39 incident and 3 prevalent HIV infections detected in participants provided TDF-FTC. Again, we do not yet have the results of drug concentration testing nor resistance testing for these participants. Given the observation of 3 early infections during the CAB arm during the oral lead-in phase, it's noteworthy that the earliest infection detected in the TDF-FTC arm was at 10 weeks on study. Given that the high levels of protection that TDF-FTC, when taken as prescribed, is known to afford, we assessed adherence to TDF-FTC in HPTN 083 to establish a benchmark by which to interpret the TDF-FTC arm incidence rate of 1.22%. Detectable tenofovir was found in plasma in 87% of samples from a random adherence sample of 400 TDF-FTC arm participants for whom data from 372 are currently available. 75% of these samples had plasma tenofovir levels over 40 nanograms per milliliter, which correlated with high levels of protection in randomized controlled trials. Additionally, we assessed intraerythrocytic tenofovir diphosphate from dyed blood spot samples in this adherent subset and found that almost 70% of samples overall contain concentrations suggestive of 4 or more doses per week of TDF-FTC on average over the previous 1 to 2 months. Interestingly, in the adherent subset, the proportion of participants over time who had tenofovir diphosphate concentrations consistent with high levels of rectal protection did not vary greatly, staying in the 60 to 75% range over at least 81 weeks, in notable contrast to clinical cohort and open label data. I will now turn to adverse events. Significantly more participants in the CAB arm experienced injection site reactions compared to those who received placebo injections. The majority of injection site reactions were mild to moderate and appear to decrease over time with repeated injection. Small proportions of injection site reactions were severe or grade 3, and 47 participants, 2.2% of CAB arm participants who received at least 1 injection, permanently discontinued injectable study product due to an injection-related adverse events. The severity of the injection-related adverse event was strongly associated with the odds of permanent study product discontinuation. The injection site reactions were 60% pain and 23% tenderness, and most commonly began a median of 1 day after injection and lasted for 3 days. The primary safety outcome is presented here. Grade 2 or higher adverse events were experienced by 92% of participants, not different by treatment arm. Statistically significant AE categories experienced by 5% or more participants in any study arm are shown on this slide. These include increased frequency of decreased creatinine clearance in the TDF-FTC treated participants, a higher proportion of participants in the CAB arm with nasopharyngitis, increased fasting and non-fasting blood glucose, and pyrexia. The majority of the pyrexia events occurred within 7 days of a cabotegravir injection. Grade 3 and higher adverse events occurring at a threshold of 2% in any study arm are shown here and were not different between study arms. Serious and expedited reporting required adverse events, which included seizure and suspected drug-induced liver injury in HPTN 083 were rare and did not differ between study arms. There were 11 deaths in the study. All were assessed by the site investigator as not related to study products, except for 1 cardiovascular event death who had been assigned to the TDF-FTC arm. Prevalent bacterial sexually transmitted infections at baseline were frequent in the HPTN-083 study population, and incident STIs are shown here. The incidence rate of syphilis centrally adjudicated is an extraordinary 16.5 per 100 person years, and aggregate rectal STIs were over 27 per 100 person years, indicating that participants were at ongoing risk for HIV acquisition via condomless sex acts. We had previously reported that in the HPTN-077 randomized placebo-controlled phase 2 study of cabotegravir in low-risk men and women globally, that the approximate annualized weight gain was 1.5 kilograms in the cabotegravir-treated participants based on 41 weeks of observation, and this was not different from the weight gain observed in placebo-treated participants. In HPTN overall, 083 overall, we observed a 1.3 kilogram weight increase annualized from baseline in the CAB-treated participants and a statistically significantly lower 0.31 kilogram weight increase from baseline in the TDF-FTC-treated participants. Interestingly, if we disaggregate the first 40 weeks of the HPTN-083 participation from later time points, we find a highly statistically significant difference in the first 40 weeks that then evaporates. Over the first 40 weeks, much like HPTN-077, we found a 1.5 kilogram annualized increase in weight from baseline in those CAB participants and a 0.51 kilogram weight loss annualized from baseline in TDF-FTC participants, highly statistically significant. However, from weeks 40 to 105, we found a remarkably similar 1.05 and 1.06 annualized kilogram weight gain in both arms, suggesting a 1-year period of weight loss engendered by TDF-FTC, but then a parallel and similar trajectory of weight gain for both agents thereafter. Work that is ongoing and is currently in progress includes the critical data of drug concentrations of each PrEP agent, an assessment of resistance profiles for HIV isolates of all HIV acquisition events. These are all in process and are of course crucial to the understanding of how best to achieve virologic suppression in the context of rare HIV acquisition despite the use of cabotegravir. Our conclusions are here. Both cabotegravir and TDF-FTC were highly effective for HIV prevention. A PrEP regimen containing the long-acting cabotegravir was superior to a daily oral regimen of TDF-FTC, with a 66% reduction in HIV infections observed in participants receiving CAB compared to TDF-FTC. CAB was well tolerated. In fact, both regimens were. Peri-infection drug concentrations and a detailed analysis of resistance profiles will be required to fully understand and contextualize these results. CAB-LA is the first long-acting injectable agent to demonstrate robust HIV prevention efficacy in cisgender men and transgender women, and we eagerly anticipate the results of our ongoing sister study, HPTN-084, comparing CAB to TDF-FTC for cisgender women in sub-Saharan Africa. Before I end, it goes without saying to conduct a massive study such as this not only takes a village, it takes a city, and I want to take the final moments to thank and recognize our study sponsor, the Division of AIDS at NIH. The ViiV Healthcare provided additional support, the HIV Prevention Trials Network, our pharmaceutical partners, ViiV and Gilead Sciences, and specifically our colleagues at DAIDS, the leadership of the HPTN, the Network Leadership and Operations Center, the clinical trials managers, our HPTN Lab Center, our Statistics and Data Management Center, our study team, our site community educators, recruiters, and CAB members, our diligent investigators at each of the 43 sites, our valued colleagues at ViiV and Gilead, the truly dedicated and meticulous teams at each site and the site staff who conducted a very complicated trial with impressive fidelity, including and specifically our sites at Fundación Huésped and Hospital Juan Mejia Ramos, and of course our study participants and their families. Although we are not able to take live questions due to this virtual platform, please always feel free to email me at this email address, or you can tweet me through the Twitter handle at DocInABox. Thank you very much for your attention.
Thanks, Dr. Landovitz. As usual, a great talk. You are by far one of the best speakers I've ever met. So the next speaker is Dr. Omar Swed, and is someone I think needs no introduction to this audience. Omar has been elected the president of the Argentinian Infectious Disease Society for the period 2021, and he represents us all in Latin Americans in the International AIDS Society, and is director of research at Fundación Huésped. And Omar is going to talk to us on the update on PrEP in Latin American countries. Please, Omar, the floor is yours.
Good afternoon. Thank you, Mauro. It's a pleasure to be here with you today for a short review of PrEP situation in Latin America. As you know, the expansion of PrEP, the scaling up of PrEP, is still very slow at a world level. It's true that we have started 200,000 new people in the last year, but they fall short of the number of people at risk. As you see on this slide, you will see that in Latin America, there's only 4 countries that have implemented PrEP programs as a public health intervention. Despite the efforts of PAHO, and which can be seen on the screen, yes, there has been progress compared with 2017. The number of countries who have drafted some policy or guideline has increased from 1 to 8, and the number of countries thinking of implementing or drafting a policy has moved from 4 to 14. However, at a global or regional level, there are only 20,000 people receiving PrEP out of a total of 600 million people living in Latin America. When one checks the regional guidelines, one may see some elements present in all guidelines, but others are missing. The diagnosis of syphilis is very common. We are seeing an epidemic in the region, so this figure is most welcome. The fact that it's been included in all PrEP guidelines, but only 27% of guidelines include the possibility for an adolescent younger than 18 may receive it, man or woman. The rest of the components vary. 73% of the guidelines use PEP as a bridge to PrEP. Only 53% recommend PrEP on demand as an alternative to daily PrEP. That only 47% use 3TC. This is very important for the region because tenofovir 3TC, because of the option of generics, is much cheaper than other options, and only 43% recommend testing for chlamydia and gonococcus, basically because of the difficulty to have access to molecular diagnosis methods for these diseases. The demographics of people on PrEP in the region. This is a diagram from PAHO representing 92% of the people receiving it or on PrEP, mostly men. And most of these men are men having sex with men. Very few women, only 5% of transgender women. And the segment, the age group that mostly benefits is young adults from 25 to 49 years of age. But what is of concern is that most PrEP concentrates only in 3 countries, essentially Brazil, where AIDS public health programs have been pioneers in the region, followed by Peru and Mexico, but only listed because of their participation along with Brazil in a very large project carried in the region. We're talking of the IMPREP project, funded by UNITAID, that tries to assess safety and adherence as well as retention in these 3 countries. The objective is focused on men having sex with men and transgender women specifically. They were expecting to enroll 7,500 people, and they've enrolled 8,300 people. It's taken care of in public health clinics and services in the 3 countries. In this very novel project, they try to prescribe PrEP immediately with no delays, with no multiple visits for assessment. And this is why during the first visit, when the participant is approached, risk is assessed to see if they are eligible for PrEP. Then a rapid HIV test is done. If negative, then they draw blood for creatinine, hepatitis B, C, serology for syphilis, chlamydia, gonococcus testing, and the medication is initiated on that very moment with a 1 month supply, and then at 1 month they have to come back for the checkup results. This was presented last year in the International AIDS meeting in Mexico. We see that sexually transmitted infections in this group is high. So this study in these 3 countries has demonstrated the circulation of chlamydia and gonorrhea. There were not many studies on prevalence there, but this coincides with other publications on the rest of the planet with a major increase of these infections, in particular in the transgender women population. If we focus on young persons, we see that the increase is still greater, an increase of gonorrhea of up to 18% in Mexico, which leads this group of young children or young men to consider this infection as a major public health problem. These are the results regarding adherence and early continuation of PrEP in these patients, and we see the differences between countries. Although retention globally was 79%, we see a major difference with Peru, where only 52% continued the visits 3 months after initiating PrEP. Other specific groups like transgender women, 55%, and youngster, up to 24 years of age, 70%. So this bespeaks the need to work on structural factors, many of them that are making it impossible, in particular in Peru, to give continuation to treatments. And this includes not just age problems or sex, but also education, socioeconomic level, the interest for getting PrEP before the study, and the knowledge or having heard of PrEP before the study. And these are precisely the conclusions of this study, which is still ongoing in the region. The main lesson is it's possible to initiate PrEP on the very first day. The possibility of positives with acute infection has been minimum. We're still working on it. We hope to get the results shortly. But retention, in particular among young people living in Peru, lower education, non-white population, and transgender women is heterogeneous. And then PrEP retention is another problem, and also STDs and the possibility of getting community retention as well. In connection with the persistence, we see it as a global problem in the last few years. In particular, we've seen more information regarding the tiredness with PrEP, the fatigue. In the U.S., persistence may get up to 40% after 1 year of treatment. So this is something we need to work on in order to ensure better benefits. And one of the points presented in the virtual AIDS conference this year was precisely that there's 2 kinds of patients, those who do not want to participate because they don't know the benefits or they fear AEs or because they think they are low risk, and those who discontinue treatment once they have accepted, many of which give up because they don't believe it effective or because they don't consider themselves a risk person, an at-risk person, or also problems regarding stigma or the need for daily adherence. So it is critical to focus on these perceptions proactively if we want to implement PrEP projects in one's country. The other survey was run within the context of the IMPREP study as well. What kind of PrEP would patients prefer? And there is a high preference for intermittent PrEP, but most people would prefer a long-acting injectable. And this is why it is good to get the HPT good news shortly. Likelihood of syphilis diagnosis. In this same virtual conference, the results were presented of this analysis of the Brazilian Health Ministry, who has more syphilis while on PrEP. 9% had syphilis. It was 8,500 enrollees. Women had 9% more than the total population. Men having sex with men, fivefold. And persons with over 10 partners, twofold more. So these are the groups on which we need to focus for a screening, a repeated screening, a frequent screening to decrease transmission and cut down these transmission chains. Working with communities, engaging the communities has been a secondary benefit of this project and also others, HPTN and others held in Peru, Brazil, and Argentina, which allowed not only greater communication, but also creating a culture of working together and engaging the communities from the very moment of project drafting or presentation to an ethics committee, all the way to establishing the best way to communicate and establish enrollment practices, the best experiences on how to retain patients in follow-up, approaching fears and doubts, and being transparent in our communication. These are lessons learned thanks to these very large projects, which have had an impact on the intention or desire of getting PrEP, as we see on this article, where the main factor was precisely having had access to information via their own communities. There are other experiences, obviously, in Latin America, but they have not had the same impact as these two. Basically, apart from IMPREP, we have the HPTN study with 2,000 people, 40% of the total project from Latin America. So we're very proud to have been able to participate. There's PrEP available from public health in Chile, although it's a small number, the same in Cuba. It's also available, but small. In Argentina, there was a pilot project that started being designed, but the COVID emergency had to interrupted because of the COVID emergency had to be interrupted. In Guatemala and other countries, they are getting external funding for the implementation of some pilot projects that are spearheading the effort in this region. But as we say in this revision, the expansion of PrEP projects is unacceptably scarce in the region, and for a larger implementation, we require political commitment, leadership from the civil society and civil society advocates, plus the involvement of scientists and the academic community in order to continue our battle for PrEP implementation. The other point of the presentation is what happens with the PrEP and COVID. This comes from 56 Dean Street, an iconic clinic in London. And we see that when COVID-19 crops up, detection, prophylaxis goes down and stays down for several weeks. And this has been a reason for alarm, not just for PrEP, but also for the pandemic and for malaria and TB. This mathematical model proposes, or unfortunately rather alerts us, that with COVID-19, we will see an increase of up to 10% in the next 5 years of HIV deaths, 20% of TB deaths, and 36% of malaria deaths, compared with if there had been no COVID pandemic. So, unfortunately, we will need to find the ways to support and keep up these programs, being innovative in doing so. What services is COVID affecting the demand for diagnosis because of fear, in particular at the beginning of the pandemic, fear of catching the COVID, so people would not go to hospitals to be tested, but also the availability of offer, because most healthcare services are devoted and saturated because of COVID. So the possibility to keep offering HIV testing, even with all of the cares, it has been considered second-line service, not within the priorities. Sometimes we physicians do not realize the impact it is having, but we need to know that raw materials to produce condoms or antiretrovirals have been delayed, not only because of production concerns, but also because of the difficulty of transportation and global distribution. And therefore, the distribution of ARDs, has been affected, although internally countries do better than the global effort. There are other programs that are being affected, vaccines, for example, vaccine schedules, general health care programs, HIV vertical transmission programs, opportunistic diseases, in particular TB and STDs, are also being affected. This is a PAHO survey showing that most countries have had some kind of an impact in their HIV service offer. There has been over 60% reduction in diagnostic and testing activities, in condom distribution, over 70% reduction of PrEP services, and also 70% reduction of community testing programs in the civil society. So this is why we need to be very innovative with our response. On the one hand, we need to try to implement tapping on the opportunity COVID is giving us to implement self-testing programs. In many of our countries, this has not been implemented yet, but the strategy provides lots of benefits, and we may tap on this in order to expand testing options among vulnerable populations or patients who are about to get PrEP, their partners, and their peers. And we need to plan for catch-up once circulation becomes more normal, in order to recover all of the people that may have been, or to retrieve the people that may have been exposed but had no access to diagnosis during this period. If we don't, our centers, then we will need to implement the protection measures of our healthcare personnel in order to prioritize high-risk persons using simpler systems. For example, surveys may be filled over the phone so that persons will not be required to be in the centers face-to-face so often. Also, opportunistic infections may be taken care of at home, self-testing at home. And to do follow-up, many of these diagnostics may be done by telemedicine with syndrome treatment, treatment of partners and peers if the STD tests have been positive. We need to make an effort to continue to distribute condoms because clearly people are not coming to our centers for them. So we need secondary distribution channels, NGOs, or public health services that are working and might also add on the condom distribution, or even private pharmacies in concert with public health authorities to have them reach people who need them. And in order to provide PrEP, we need to think of how to change our healthcare model so as not to need the patient in the presence of the person, of the patient, face-to-face. We can do counseling, assessment, and prescription of PrEP by telemedicine. And if we can prescribe every 3 months, the person would only need to attend the center every 3 months so as not to expose the patient or overload the healthcare systems. Brazil has published on telemedicine the possibility of self-testing for diagnosis. The person contacts the healthcare system by telesystems. They may also ask for PrEP and look for the medication for 3 months, and at that point, every 3 months, be checked up if necessary. For example, laboratory testing. It's an experience that maybe could be expanded to other cities in the region. And finally, a touch of color or note of color. We know that we are now assessing whether some of the medicines used for PrEP do have an impact on COVID mortality. This is a study on 3.5 million people in South Africa, public sector effort, and we see that those who were receiving tenofovir had 60% less risk of dying from COVID than HIV-positive persons receiving other antiretroviral treatments. So based on this experience and others, COVIPRED and EPIC projects were created to assess the impact of tenofovir alafenamide to do prevention for healthcare staff. Another large study, 70,000 people in Spain, those receiving tenofovir, not TAF, but tenofovir, they were not associated to risk of death compared with other drugs. All of these studies are plagued with confounders, so we need more randomized studies for healthcare people to work on this and identify whether these drugs have an access and a value to respond to COVID. PrEP implementation, in conclusion, has been slow in Latin America. It has been led mainly by the PrEP program in Brazil, as well as the project HPTN 83 and IMPREP. COVID has affected all PrEP plans in the region, reducing them, and this is why telemedicine and the possibility to have long-lasting injectable regimes might facilitate the scaling up and acceptability among those who most need it. This is why we need to be innovative to accelerate the catch-up effort required as soon as the pandemic fades in order to reach our targets and eliminate HIV as a public health problem. Thank you all. It's been a pleasure to be here with you. In particular, I wish to thank Giovanni Ravasi, Beatriz Greenstein, Valdilea Veloso, Cesar Bonifaz, and Pedro Can, who have helped me with many of the slides, and all of the Fundación Huésped staff, which has made it possible for me to do my job and then interact with them in all of our job. Thank you very much.
Thanks, Dr. Thank you, Omar, for a very nice presentation as usual. And now we move to the third and last talk of this evening, entitled HIV Diagnosis in the Area of PrEP, which will be given by Dr. Bernard Branson. Dr. Branson is well known for his work in HIV diagnosis. He joined the CDC in 1990 and served as Associate Director for Laboratory Diagnosis in the Division of HIV, AIDS, and Prevention for 11 years prior to his retirement in 2014. And since then, he's been providing expert consultation HIV diagnosis and continuing medical education and lectures in several settings. So it's my pleasure and honor to introduce you to Dr. Branson. The floor is yours, Dr. Branson.
This first slide shows my disclosures. I was formerly the Associate Director for Lab Diagnostics at CDC, and I do serve a consultant to the Gilead Sciences Focus Program, which supports HIV screening. I will use occasional brand names in this presentation only for identification, but do not intend to endorse any specific tests. HIV tests have gone through a series of evolution in terms of antibody tests, first approved in 1985. The first generation was based on a whole viral lysate and it detected only IgG antibody. The second generation was an improvement by using synthetic peptides instead of the viral lysate, but still detected only IgG antibody. Major change happened with the approval of third generation assays, which were able to detect both IgM and IgG antibodies, and most recently the introduction of the fourth generation assays, which detect P24 antigen and both IgM and IgG antibodies, has allowed us to reduce the window period for testing. In general, there's been a recommendation to not use the generation term anymore, but instead to refer to tests on the basis of the things they detect, because the generation topic is somewhat, they're imperfect as a description, but it has been a useful classification. The first and second generation tests, which were both indirect EIAs, and so they used either viral lysate or recombinant proteins or synthetic peptides. When you add the specimen, they would bind both IgG and IgM antibodies, but for detection, they used the anti-human IgG so that only IgG antibodies would give a signal on the test with a color change in the EIA when IgG was present. The sandwich principle, the third generation principle, uses the same kinds of antigen, which is recombinant proteins or synthetic peptides, but instead of the anti-human IgG, it actually uses an enzyme labeled HIV antigen, so that when the antibodies are present, it creates a sandwich between the antigen in the liquid phase and the antigen that's bound to the plate, and so either IgG or IgM antibodies, or both, will develop a signal and a color change with the presence of antibodies. The fourth generation is pretty much like the sandwich principle, except it adds a monoclonal anti-P24 antibody to the mix, and again uses the enzyme label of HIV antigen and P24 antibody if it will bind to the P24 antigen if it's present, and so either antigen or antibody will give a signal, but most of the tests do not differentiate the presence of antigen from antibody, so that the presence of either will give a reactive test result. The difficulty with the generation term comes up in using rapid tests, which have gained widespread popularity. Rapid tests use plasma or serum. Some can be performed on whole blood or oral fluid. And in the presence of antibodies, they are then bound to a colloidal gold in the bound to protein A. Protein A is a very active anti-IgG and some activity against IgM enzyme, but in general, these are indirect EIAs, similar to the initial immunoassays, and they basically will bind mostly to IgG antibodies, and the control on the test is anti-human IgG antibody. And so these really are much more similar to a second generation assay than to the third generation, and certainly compared with the fourth generation. If we look at the virus itself, we have a picture of the antigens and the RNA that are present in this schematic of the virus. And in general, the tests that constitute a positive Western blot assay were the GP120 and GP41 surface proteins, and then the P24 core protein, which is present in much less quantity than the GP120 and GP41. The rapid HIV tests pretty much all detect either GP41 and 120 or GP41 only. So they detect really only the surface antibodies to the surface antigens of the virus. The test currently used most often, if I would ask this question, people would usually select EIA or enzyme immunoassay. That's mostly from habit. But in fact, the tests used most often currently to detect infection are the CIAs, or chemiluminescent immunoassays, or none of the above, which are different assays. The lateral flow assays, as I mentioned, are in widespread use. And so if we look at the tests, at least the ones that are FDA approved in the United States for diagnosis of HIV, we see that only one of them that remains on the market in the US is an EIA. That's the Bio-Rad fourth generation or antigen antibody combo assay. And the other assays are all chemiluminescent assays, or CIAs. And a chemiluminescent assay basically usually has magnetic particles that are bound to the antigen in the presence of antibody, or in the case of a P24 antigen, in the presence of the antigen that binds to those magnetic particles. The magnetic particles are then activated with a fluorescent ester after a wash step to get rid of the excess particles. And with the presence of the trigger solution, these assays emit light. They're chemiluminescent, which gives them a much wider dynamic range and a very high specificity. They can also be done quickly. The incubation periods are shorter than with EIAs, and they can usually be well suited for multi-platform analyzers where multiple different kinds of tests are done on the same specimen. The newest technology is the multiplex flow immunoassays. This is the Bioplex antigen antibody combo that was approved by the FDA in the US in 2015. It uses beads that are conjugated to antigens of HIV-1 and also P24 antibody. And in its result, it distinguishes between reactivity from antigen versus HIV-1 antibodies versus HIV-2 antibodies. And in fact, this bead technology really lends itself well to multiplexing. Originally, the manufacturer had attempted to determine a fifth generation assay, which led somewhat to the abandonment of use of the generation terms entirely. You can also add beads, for example, for HCV antibodies, for the RPR and treponema syphilis antibodies, in order to do multiple different examinations on the same specimen. So the new terminology that's really been adopted in general is instrumented lab test versus single-use rapid test. The antigens that are used by these different tests are listed in this slide. You can see that the third generation instrumented antibody tests used P24 or detected P24 antibody, as well as antibody against the surface protein, GP160, GP41, but the fourth generation assays, because they detect P24 antigen, they cannot assess for antibody against P24, and so the P24 is detected, the antibody to P24 is detected in the third generation antibody only assays, but in the fourth generation, or the antigen antibody combo assays, the antigens that are used are pretty much the same as those in the single-use rapid test, GP41 and GP160 or GP120. So they're only surface antibodies to surface antigens are the ones that are detected. In terms of the overall time frame of the development of laboratory markers, this schema gives a little bit of a map looking at days from the time of infection. Infection occurs at point 0, and initially there's an eclipse period where nothing is detectable, no virus, no RNA, and no antibodies. At the end of that period, plasma RNA becomes detectable at usually around 10 days or so from the time of infection. That initiates the period of acute infection when RNA is detectable, and for a short period, P24 antigen will be detectable before antibody develops. Once antibody, this is also termed Fiebig stage 1, excuse me. And I will refer to these Fiebig stages somewhat later in the talk today. P24 antigen shows up around 2 weeks after the time of infection. It's detectable a little bit later than RNA. And then as antibody develops, the P24 antigen binds to the antibody, and antibody remains detectable, but antigen does not. The presence of RNA and P24 marks the onset of Fiebig stage 2, and then the presence of antibody, first IgM antibody and later IgG antibody develops, so that the detection of IgM antibody only with P24, with or without P24 plus RNA, is a period of recent infection, and then that's the Fiebig stage 3 infection. And at the end of the period of recent infection, when IgG antibody becomes detectable, that's Fiebig stage 4, which persists through the whole long period of long-standing infection. A fully developed positive Western blot, this is antibodies to several different HIV antigens, marks Fiebig stage 5, which is the present during the entire long-standing phase of HIV infection. The Fiebig stage 6 is the later infection when the antibody has developed in the Western blot, some of the less specific antibodies, and that again remains throughout the course of infection in most people. In terms of test positivity relative to the Western blot, what we're able to measure basically is when the RNA test turns positive. This is the Aptima qualitative RNA approved for diagnosis in the United States. We can also tell when the Western blot turns positive and then figure out reactivity in terms of days with respect to when the Western blot became positive, so that the rapid point of care tests show up first, and they usually take somewhere around 4 weeks from the time, well, actually they're positive around the time the Western blot is positive, nearly 4 weeks after the time RNA appears. The third generation antibody assays show up about 2 weeks after, before the Western blot turns positive. The antigen antibody tests with the detection of antigen then show up nearly 3 weeks before the Western blot turns positive. But the question people really have is, what is the window period, the time from infection until the time the test turns positive? And that varies with the different tests, but in particular, it required a calculation to figure out how long the eclipse period was, since we don't know the date that people got infected in order to measure in these laboratory experiments. So the eclipse period was modeled using Monte Carlo simulations to look at the time between HIV acquisition and the time of the RNA reactivity, and that modeling demonstrated on the basis of certain observational experiments that the mean eclipse period was 13 days, median about 11.5 days. And so adding that to the time the other assays turned positive, we're able to estimate the window period both in median and in the 99th percentile. Excuse me. So to repeat this slide, using that estimate of the window period and adding it to the observed time the tests turned positive with respect to the Western blot, we're able to calculate the median and the 99th percentile for the window period. The median for the antigen antibody instrumented tests is about 17.8 days, 99th percentile, 44 days. And of course, the Western blot at the other end of the spectrum, based on whole viral lysate, has a median of 36.5 days. That's nearly a month after the time of infection. Now, the estimate for all the other tests, the single-use rapid tests and the supplemental tests that are sensitive to IgG, like the Western blot, which only picks up IgG, are all pretty similar in their time of detection. The 99th percentile is useful, however, because it helps to answer the question, when can I be sure? And obviously, in testing for PrEP, we want to be running the antigen and antibody tests on people if we can, in order to identify possible breakthrough infections as soon as possible after the time of infection. For a person who has not received treatment, the 99th percentile is out at around 44 days. for the antigen antibody tests that are instrumented, and it's considerably longer for the IgG sensitive tests. Out here, we're looking at times that are about 8 weeks from the time of infection. And so retesting is recommended if a person has been exposed at about 6 weeks after the time of exposure from an instrumented antigen antibody test, or more after 3 months for a person who's using a rapid test or other IgG sensitive tests. And so that is a considerably longer period of time than, of course, this median estimate that we have. Antiretroviral therapy is being initiated earlier and earlier in individuals, and the effect of that therapy is really important in terms of what it might mean for people who are treated during infection with PrEP. So that during acute infection, what they have observed is that there's a high rate of non-reactive HIV serology in people who are treated during the period when only RNA or RNA and P24 antigen is present. This is a somewhat complicated relationship. This is the response that we looked at earlier, the antibody response to HIV without treatment. And looking at this same map schema in these people who were treated early, what we see is that the antibody rises up and in some cases does not quite reach the threshold of 3rd or 4th generation antibody positivity. And most of these antibodies will not meet the threshold for IgG antibodies here of the 2nd generation test, the threshold at which the test begin to detect it, because the antibody response is blunted. And in particular, it is blunted for the GP41 and surface membrane, so that now that the assays don't detect P24 in the newest assays, they may have a higher likelihood of being false negative in people receiving early treatment. If the therapy is initiated early, these are the schema, and it's a little bit complicated in terms of the graph. So looking at 2nd generation assays, 3rd generation assays, and 4th generation assays, and the shading of the bars is represented by the phoebic stages here. But this map looks at non-reactivity on the y-axis of the graph over a period of 24 weeks from the time the treatment was initiated. And so what we see in general is that these phoebic stages have different effects when treatment is initiated on how subsequent assay reactivity occurs. So that looking overall in people who were treated at 24 weeks after the time of infection, what we see is about 33% of people are negative on these 2nd generation assays, which would include rapid tests and the Western blot. Only 4% are negative on the instrumented IgM sensitive, IgG sensitive assays, and about 17% are negative on these antigen antibody combination assays, higher than on the percentage of the old antibody tests. We look at the people who are RNA positive and P24 positive at the time of treatment is initiated. Here at 24 weeks after infection, what we see is that all of these individuals were reactive on the antibody 3rd generation tests, but about 18% of them were negative on the 4th generation assays. And for people whose treatment is started only when RNA is present before antibody or antigen is detectable, what we see is a substantial percentage of individuals, nearly 60% of those who were treated when only RNA is present were negative on these antigen antibody combination assays, compared to a much lower percentage, about 18% of individuals who were not reactive on the 3rd generation assays. And so this 4th generation assay performance is very similar to the rapid test or the old IgG sensitive assays altogether. And as I indicated earlier, I think that that can be explained because of the 3rd generation assays detecting antibodies against P24 compared with the antigen antibody combo assays that only detect GP41 antibodies. I'm running a little short of time, but on the horizon, what we see is the current algorithm in the United States starts with the antigen antibody assay for diagnosis and then goes on to the differentiation assay. And if the antibody differentiation assay is negative, you want a nucleic acid testing. What I think will probably make sense as the next step is starting out with the antigen antibody immunoassay and then using HIV-1 RNA viral load as a second test if that first test is positive. Using that as the second test will basically identify the people who have detectable virus and lead to treatment initiation earlier, and given the specificity of the test, 99.6% of those of the positive first test will indeed be truly positive, and so we'll take out that second step of antibody detection. For those who do not have detectable RNA, you would then go on in order to do antibody differentiation testing to look for HIV-2 or to look for the presence of antibody, because this circumstance in particular might occur in a person who's effectively treated and has undetectable virus. And then you can determine who's HIV infected on the basis of the presence of antibody, or if they remain negative, you would then go on to do an additional test, potentially another antigen antibody assay, in order to look for congruence in the test results. The viral load is something that we would want in most patients anyway at the baseline, and so that sort of eliminates this unnecessary extra test for a large number of people, and allows us to then use these new point-of-care nucleic acid tests. While these are not yet available in the United States, they're widely available outside the US, including this one, the expert viral load, which is available for HIV and HCV, which is CE marked for use in the European Union. There are two others, the MPIMA and the SAMBA2 tests, both of which give results in an hour or less near to or at the point of care. So in summary, the HIV tests differ in ways that can affect their performance in different circumstances, especially in individuals who've been treated early, and evidence is accumulating in folks who get infected, breakthrough infections while on PrEP. So RNA and viral load is going to play an increasingly important role in HIV diagnosis. And as I had demonstrated, the early treatment, which includes PrEP, can lead to non-reactive serology and undetectable RNA. I'd like to thank you for your attention.
Well, I'd like to thank the three speakers for incredible talks. And I'd like to remind the audience that you can send questions, as many questions as you want. And it's not always that we have the opportunity to have all these three speakers united in one table. So I'll start by asking the first question, and I'll go to Dr. Landovitz. And one thing that impressed me when you presented these data is obviously, I think no one expected, not even you, that the difference would be superiority. You thought probably they would be equivalent, but not that it would be superior. Am I correct? That it had a threefold difference? Did you expect that?
No, Dr. Schechter, you're exactly right. We did not expect that. The statistical design of the study actually was predicated on cabotegravir being 25% better than Truvada. That was in the statistical hypothesis on which the sample size was based. And I think we thought of the reason that was biologically plausible is because we anticipated that the agents would be independently equally effective, but that the structural barriers that accompany the daily oral Truvada use would be improved on in terms of coverage of sexual acts with the long-acting injectable. So that's why we thought a 25% improvement would be a reasonable assumption. So we were indeed incredibly surprised when the study stopped early with that large a difference. But I still think that the overwhelming, most likely explanation is the original hypothesis, which was that cabotegravir structurally provides better coverage of sex acts than does daily oral Truvada in this population. I think the worst thing we would think would come out of it would be someone to think that this means that Truvada is not an outstandingly effective prevention strategy. It's just if you have trouble adhering to it for use at which you would get high levels of protection, here is something that may make it easier to get that level of protection.
It's the old aphorism by Everett Koop, isn't it? Pills only work if you take them.
If you take it, exactly right, exactly right.
But were you surprised the number of failures? I mean, 13 of the 13 that failed cabotegravir, if I recall correctly, but there were 5 at least that should have proper blood levels because they were on time for their shots, and they had enough shots to think they'll be protected. What's your hypothesis there?
Yeah, thanks. That's obviously one of the most puzzling things as we have look at the data that were available to date. We're obviously working very hard to look at the pharmacokinetics of all of the cabotegravir seroconverters, and those 5 in particular. It makes you wonder, is there something about those participants that they had lower levels of cabotegravir than was expected? Or is there something else going on? Were there ulcerative rectal STIs associated with those diagnoses, which might make it less robust? We know that Truvada retains extreme levels of robustness in the face of ulcerative STIs, but cabotegravir only gets about 8 to 10% of its plasma levels in rectal tissue. That might be an area of vulnerability for it if there are ulcerative STIs. So I think we have a lot of triangulation of data to do to fully understand those cases. I think what makes me feel better is it's such a rare event that there was a failure, but obviously we're going to interrogate each of these failures in a lot of detail because we need to understand them better.
Rafi, did you have resistance information on all those people with breakthrough infections?
We don't yet. That's in the process of being accumulated, and we are hoping to be presenting that at a conference soon. But obviously, that's really critical. You wouldn't expect integrase resistance to be transmitted because that's not been documented to be circulating at high levels. But what the consequences are, if you will, of failing an integrase-based regimen could have important implications on what you would treat them with first line and on the global scale, whether or not WHO recommended first line regimens would be effective for that suppression, or if you need more information that would be more resource intensive to create a suppressive regimen.
But the tenofovir resistance might account for potentially some of the infections in the control group, right? In the tenofovir group?
Sure. And again, we don't have that full information yet. I'm going to wager, if I were a betting man, that the overwhelming majority of the failures in the Truvada arm are going to be due to non-adherence. But you ask a really important question: is could some of them be attributable to circulating K65R with one M184V together? Because you certainly wouldn't expect M184V alone in most regimens to account for that.
Let me take advantage of the presence of Dr. Branson, one of the world's experts on diagnosis. One thing that people always are worried about is first the ones who start PrEP being in the so-called window period, and those who circumvert or get infected while on PrEP.
Right.
Can you talk a little bit about the challenges, diagnostic challenges in these two situations, and what can we do?
Yeah, as I talked about, it is a challenge for diagnosis, although a lot of the people do end up getting detected because they are getting, most of them, tested more frequently so that they will be identified. What we've encountered, including in this particular study that Rafi had talked with me about, are a lot of people who have very confusing test results. At this point in time, I think, however, that it really is making sense both for these patients and for others who test positive to go directly to a nucleic acid test after they have a positive initial test. The whole old way of doing an antibody test after an antibody test, I think, is pretty dated given how easy and how widely available the nucleic acid tests are. And while they don't resolve all the ambiguous cases, I think they resolve a lot of them. And I think that we have now more availability in order to look at people directly on the basis of what's happening with their virus as opposed to what's happening to their reaction to the test. So, still we'll be screening, I think, with antigen antibody combination tests, but a lot of these people with early infections with PrEP are positive, at least transiently, for the antigen on those tests. And I think that probably going directly to a virus test is going to make the most sense, both for them and for other infected people, because we'd like to get them onto treatment as fast as possible. And it doesn't seem to make any sense to go to an intermediate antibody test that doesn't really offer you any additional information.
What about, because these tests, point of care, they're quite cheap in Africa, but they're quite expensive for us. Do you see them getting cheap everywhere around the world, in the point that you can get away, just not need to use antibody tests and go straight to PCR to all of them, viral loading everyone?
I think that, what has happened really is that market outside the U.S. has been driven by the need for infant diagnosis in maternal to child transmission, and that in the developing countries, a lot of the nucleic acid tests are now less than $10, or I should say several, not a lot of them. And we're not lucky enough to have that in our developed countries like the United States. And I think that what we are going to see is a continued reduction in those prices as the technology becomes more widespread.
So let me change a bit the subject, go to Omar. And Omar, you are one, at least in our region, one of the persons who knows the best, has worked the most with transgender populations. Can you talk about a little bit about the challenges about working with these populations? And one population that's I always feel sort of left out is transgender men. Can you talk a bit about them and transgender women?
Thank you, Mauro, and hello, Raphael and Bernie. It's a pleasure to see you. I am so sorry we cannot be together and having a good time, in particular with the success of HPTN or OA3. And thank you, Raphael, again, in name of all Argentina, because if not for you, it will be impossible to have HPTN here in Argentina. And this is good to say thank you for that.
So to interrupt you, Omar, we're also sorry that we're not in Buenos Aires with you right now. Okay.
I hope the next year we will do. But I got to your question, Mauro. I think that we have so many layers of vulnerabilities together in transgender women, in particular, more than in transgender men, because transgender women, because of the machist culture, are expelled from home very early in the adolescence, so they don't have any other option that go to sexual work in most of the cities. And it's different from Asia, where probably the social norms are different. But here in Latin America, in particular in South America, Brazil, Peru, Argentina, is a very complex situation and are the most exposed to HIV with more than 100 partners every month, unprotected sex in more than 50%. So it's a perfect potential user for this kind of technology. And actually what we see here in the protocol is a very high acceptability and a very high retention to the injection and not to the pill. So it's probably the good opportunity to think about that, but also to think that we need to change also, or to plan in the future in how to go to the home of the people, or to the sexual venue, the work venues, or places where the transgender socialize, to do the right test at the moment, to having the rapid test, and to propose the prevention treatment, test and treat, test and prevent, something in this kind of approach. So I think good opportunity in the future. And I think that COVID, unfortunately COVID appeared, but fortunately COVID will improve the capability of the country for the molecular diagnosis in all the countries, will reduce the price, and will improve also the contact tracing teams in the country that will be beneficial for this kind of approach. I'm sorry for the trans men. Sorry, I missed this part of the question. We have a survey for 400 transgender men. What we can see here that nobody knows really well when everybody of us think about presumption, and you presume the transgender men are people that are not exposed to risk. And we see here in the survey that 25% of transgender men have sex with other men, and so they are transgender men, gay men, and so they are exposed to high risk of HIV, and they don't have access to discuss this with the providers, and it's really an important population that we need to take care also. Even though they don't have the vulnerability, the social vulnerability that transgender women has, but they don't have the community effort and the community protection that the transgender community has. So it's this part of the equation, and we need to work together in looking for this kind of vulnerability.
Thank you, Omar. I think we're running out of time. On behalf of Virology Education, and I'm speaking on behalf of Charles and Alice, I want to thank all of the speakers. I want to thank also those at Virology Education, Huésped and Nina, in particular, that worked very hard. And on your side, thank you, Omar, thank Pedro, thank Micaela, and everyone who worked very hard to make this possible. And hopefully we'll be in Argentina next year with another symposium from Virology Education. And without COVID, all of us be able to drink a proper wine, a good Malbec in Buenos Aires. So
Good.
Thank you very much indeed.
Thank you.
Thank you.
It's a pleasure to see you. Okay, thank you very much to everybody that was connected until this time and this